It's time to remove the mystery from medicine, to seize control of one's health, and to genuinely comprehend the essence of terms like wellness and wholeness. The Ask Dr. Jill podcast provides information, knowledge, and empowerment information to empower you to be wholly well. Dr. Jill Waggoner has nearly 3 decades of medical practice and has a deep-rooted belief in diverse approaches to patient care, well beyond conventional medicine. This realization has fueled her lifelong pursuit of understanding a holistic perspective on health.
Hello, welcome back. I'm so glad you guys decided to join us again. We are picking up where we left off last time. We are still talking about hormones. Let me tell y'all why I like talking about hormones. Because there are so many people that are interested in it. There's so much misinformation out there. And so if we can have a conversation where we talk about it and you get good quality information, so as you make your decisions, you'll be able to make it with some knowledge, then I'm all about that. So today I have a guest. Yay. Hey, Nick. Today I have Dr. Nick Miller. Nick is a PharmD. He went to pharmacy school at the University of Houston, and you've been a pharmacist since what, 2016?
2016.
Yay, something like that. So long enough, he's grown now. At first,
I've got a few gray hairs.
He's not a baby pharmacist anymore. He's a grown pharmacist. I was looking at some stuff about you, and it says that your personal mission statement is to simplify the complicated.
Yes.
I think that's great. So that's what we're here today, is to simplify the complicated. So we're going to talk all things hormone replacement therapy. Now, I want you to know this. It's going to be in my stuff somewhere. This is not medical advice, guys. This is information. So you can do with that information what you want to do. But I think it's important that we give people real good information. So I gave you just the skinny about who Nick is. Tell us who you are, Nick.
Thank you, Dr. Waggoner. And I
You're
appreciate
welcome.
the opportunity to come on. Such a cool experience. So thank you so much.
Thank you for coming. You know, we've known each other for years.
Yes.
Whenever I have information or questions, guys, I can call. And by the way, he's at Pharmacy Solutions, compounding pharmacy. Whenever I have questions, I can call, get Nick on the phone. He knows who I am. I can ask a question and he'll give me real information. And that's what you want to have. Okay, I just wanted them to know that.
Oh, thank you.
Mm-hmm.
Yes, so my name's Nick Miller. I'm a pharmacist at Pharmacy Solutions. We're a compounding pharmacy in Arlington, Texas. I've been in my role as a pharmacist for 8 years. However, I've been in the compounding world since 2011. Started working as a technician when I was going to UT Arlington, getting my biology degree. So very passionate about it. And what kind of brought me into it is I was trying to get into pharmacy school. I was trying to bolster my resume, trying to get as many accolades as I could so that I could apply and be accepted. And so one of those things that I wanted to do is I wanted to start working in a pharmacy. So this was, I hit the road, I printed out all the pharmacies on MapQuest. I knew I didn't want to work at a chain. I wanted to work in a small business, independent type pharmacy. Printed out all the pharmacies in the DFW area for the most part that ticked those boxes and went in and tried to get my face out there. And one of the very first ones that I went to was Pharmacy Solutions. And they gave me the opportunity. But I didn't know anything about compounding at that time.
Yeah.
I went in and my role was to, kind of answer the phone and ring people up, count a few pills here and there. And I asked the pharmacists that were there, Mike and Tom, I asked them a ton of questions. So just day in and day out to try to learn whatever I could. But really what I started to notice, as scientists, we're observers. We have to observe things and look for patterns and trends. And one of the things that I started to notice was that the people that were coming into the pharmacy, they looked different than I thought they would.
In what way?
Well, mainly I would look in the computer, I'd see their profile, I'd see that they were born in, 1958, 1965, whatever it may be. But the person that was standing in front of me didn't match what I anticipated that they would look like.
Looked healthier, younger.
Healthier, younger. The skin was
more
tighter.
vibrant.
Yes, they had almost an aura or a glow about them. They were in a better mood
Sure.
a lot of the times. And I didn't really make the connection right then. My first observation was, something is different about the people that are coming here. But as I learned more, found out, well, this patient is picking up a progesterone capsule, or this man is on a testosterone gel, or this lady's on an estrogen cream. And so then I started to notice that those two things were associated with each other. And so that's kind of what started my journey. I could see the actual effects of the hormones into, I was naive to the entire thing. And so, it just blew my mind when I saw that.
Yeah, that's interesting. I always say that I can look at people who are postmenopausal or who are over 50. And I can tell you almost by looking at them, looking at how they walk, looking at what their skin looks like, whether they are doing any things to maintain their vigor.
Yes.
So that may be hormone replacement therapy, that may be some kind of supplementation, their diet is good, their exercise. You can look at people and tell because they age differently.
You're right.
I want to ask you a question before we go any further. Tell the people what a compounding pharmacy is, because we are assuming that everybody knows. But what's compounding pharmacy?
Yeah. So compounding is, I describe it as, it's kind of the old school way to do things. Okay. It's the way that pharmacists of old, back in the times before the Industrial Revolution, people would go and see their local pharmacist, and he would mix something up for them specifically for whatever ailment they had. That could be herbal things or liquids or elixirs, tonics, that sort of thing. Well, that sort of practice still exists today. And what we call that is compounding. And so as a compounding pharmacist, we make things that are, perhaps we have a child that's allergic to red food coloring and needs amoxicillin suspension. Well, at CVS, all the amoxicillin suspension is bubblegum flavored and has red food coloring.
Right.
So I can make the amoxicillin without the red food coloring. We'll go into hormones, of course. There's lots of different things we can do with hormones, but I can make things that have been discontinued. I can make special doses. We basically fill the void where the commercially manufactured products, maybe they don't have an option for the patient. And so we make custom things for people and animals and all sorts of cool stuff. So problem solving.
I think that's real important for people to know that today you still have available to you somebody, a pharmacist who can give you something different, because a lot of people have issue, whether it is a physical reaction to, or they just don't want to put the dye in their body.
Sure.
So if I'm trying to get well and I don't want the dye, I can do a compounding pharmacy. I always tell my patients though, insurance may not cover this.
Right.
And so you almost have to have a level of understanding that there are some things that I just purchase for myself if I want the best of it, the best option that's available for me. So I think that's a real good thing to know. So hormone replacement therapy, there's people are all over the place. There's so much information. I remember when the Women's Health Initiative study came out. What was it, 2012?
It was, I think it might have even been earlier than that.
Yeah.
2000, 2001, something like that.
When it first came out, I remember, and they broke the news and said, women should not do hormone replacement therapy. And I'm going to let you kind of talk about what that looked like from a pharmacist perspective and working in the pharmacy. But I had all these people who came in and said, I have to stop this right now. So we stopped their hormone replacement therapy. In about 2 months, they were all back and said, listen,
right.
I cannot think, I cannot function, my joints are hurting. This worked for me. What can we do? Which put me on the journey of what is bioidentical hormone replacement therapy and what does that look like? So if you would do a couple of things, there's so much information I want to cover, guys. We may have to do a part 2. But so first of all, talk about that study and what that looked like and what the findings were and that kind of thing.
Okay, very good. So I like to set the table. So let me set the table on that. So when people come to the pharmacy, some of the biggest concerns that they have about hormone replacement, they're concerned about things that they've heard from maybe the media, maybe from family members, maybe from their doctor, about potential blood clots, strokes, blood pressure issues, cancer. The biggest thing are clots, strokes, and cancers. And a lot of that stems from this study that was done. And really, if we take just kind of a step back, and I'm sure your listeners are familiar with generally hormones, but kind of what I would characterize it as, a hormone is just a messenger molecule, right? It's one part of your body secretes a hormone, and that travels to another part of your body, and it tells that part of the body to do something. Okay, it's a message. And so I kind of use a simple analogy for it. The hormone, it's kind of like a key. We're putting it into a lock. Okay, and that key, it needs to go into the keyhole to be able to open it.
Right.
Well, our cells, we have keyholes all over our body. We call those receptors, right? So that hormone, that key, we've been created and designed for certain keys to fit in our keyholes and open our locks, so to say. And so with hormone replacement, really what we want to do is we want that key to be the same thing that our body is used to, the same molecules that our bodies were created with. The Women's Health Initiative study and others that were done, they were using things, synthetic hormones. They were using hormones that were extracted from animals. The famous one is Premarin.
Which is from mare's urine.
Pregnant mare urine, Premarin, the brand name.
And mares, horses.
Horse, yeah.
Okay.
And so they were using substances that were not natural to the human body, or they were using things that were synthetic. And so have you ever been trying to get into your house at night? You're trying to put the key in the hole. You may be fumbling around, choosing. Some of those keys will fit in the hole, but it doesn't turn the lock the way it's supposed to.
Right. They look the same.
Yes.
But they are not the same.
Exactly.
So that's what's important. And I think that's a real important point, is because you will have people in medicine, conventional medicine particularly, who will say there's no such thing as bioidentical. So bioidentical is a term that means it is a hormone that looks like the one you make in your body, and it fits the receptors in much the same way.
Exactly.
Is that a good explanation?
Yes, ma'am.
Yeah.
Yep, that's perfect.
And the reason that matters is because if your body doesn't recognize it, it doesn't know what to do with it.
Right.
So it's like, what is this? I've never seen this before. I don't break it down the same. I don't use it the same. All of that's an issue. Okay, go ahead.
Yeah, so you're exactly right. And so it really just depends. The body's response is going to be dictated by how those receptors are activated. And so we were meant to react in a certain way to estrogen and progesterone and testosterone, not the synthetic hormones, not pregnant mare urine, right? Those things are going to not elicit the response that we want in the human body. And so when that study was conducted, they used conjugated horse estrogens from the urine, and they used synthetics, and surprise, surprise, they found that there were some adverse effects to using those molecules. So that's where the press came out about using, they used, the term progestins, which is kind of an umbrella term, and estrogens, right? And so a lot of doctors and pharmacists were kind of misinformed. It was mistaken identity. All those things are true about what they found in that study, right? But the vast majority, certainly what we're talking about today, of hormone replacement is not using those molecules.
Right.
And so the bioidentical, we try to minimize all those risks as much as we can, and they're much, much lower than the study would lead you to believe.
Right. So that's good information to know. So when you are talking to someone who has come into the pharmacy, because they actually, if you go into the pharmacy, your doctor has sent you there, they will sit down and talk to you about it so you can get information and kind of what works for you. And then the doctor will give the prescription that gives you those things that you need to have. And I think that's real important to know. So let's say you're starting out, you're talking to somebody and they're trying to make the decision about whether this is a good option for them. So first, can you kind of talk about what symptoms you're thinking about? I know what symptoms I know about. So you talk about what symptoms you're talking about, and then what different hormones are available.
Okay.
And how do you give them? Do you give them by mouth? Do you give them across skin? Any of that? I know that's a big question.
That is a big, big question. We talk probably for the rest of the time. So, but so mainly what's going to drive people to seek relief from their physician or bring people to the pharmacy asking us for a solution is going to be those symptoms, right? Typically, the stereotypical ones, you have hot flashes, night sweats, we call those vasomotor symptoms. Those are dramatically impacting quality of life in the female patient. They could have energy and fatigue issues. They could have some weight gain around the midsection that they just can't get off no matter what they do. They could have trouble at work with focusing, brain fog. They could have trouble with libido and their impacting their marriages. And so all of those things are pretty typical. And I kind of describe it this way. Men and women, different creatures.
Right.
Women, you are
Thank
beautiful.
God.
Yes, beautiful, yet intricate and complicated creatures. Men, we're a little bit more simple when it comes to hormone replacement. Maybe we can talk about that another time.
That is big.
Yes.
That is really big because men essentially have one reproductive hormone and it stays the same. They have some of the others, but they have one main one that stays about the same from puberty on until it starts to fall off. Women cycle every month.
Yes.
So they have several hormones and they cycle every month, which is very complicated and complex.
There was just a fabulous doctor in the Dallas area named Dr. Jill Waggoner who once,
I've heard of her.
Yes, once she used the illustration of women's hormones being like a symphony.
Yeah.
And that's always stuck with me. You have all these different parts playing their role.
Yes.
I mean, it's beautiful the way that it's been created. You have the interplay of this estrogen and progesterone cycling through the month. That's what creates fertility, creates the ability to have children. And it's amazing. But yes, men, we're much more simple. Ours just kind of stays the same.
Right.
But when a patient comes to us, my role as a compounding pharmacist especially, working with good doctors like Dr. Waggoner, we want to create a solution that's custom for that patient's lifestyle.
Right.
And so we want to look at the labs. So the patient comes to us, we have some symptoms. From those symptoms, we can begin to gather, hey, these hormones may be implicated here. And then we can look at the lab work too. Say, oh, well, the testosterone is very low and estrogen seems to be okay. Maybe she's 42, still producing a little bit, but the point is we get kind of a picture of where she's at that point. And then we can work with the doctor on addressing some of those symptom complaints specifically through certain dosage forms. And so I can go into some of the hormone actions.
Absolutely. So overall, when I'm looking at patients, and we kind of do this, all collectively, vasomotor symptoms, which are usually the hot flashes, guys, that's usually estrogen.
Yes.
Women who can't sleep, I find that that's often progesterone. Because when the progesterone, which I call the calming hormone, when it's disrupted, and that's usually one of the first ones. So women will say, I can't sleep. I'm waking up at 3 a.m, I can't function. So that's usually that one. And when their libido takes a dive, because women, your libido will dive too, that's usually testosterone. A lot of women don't know that we have testosterone, but that's usually testosterone. And so you are correct. Whatever is their main focus kind of lets us know where they have a key deficit, and we always do blood work.
Yes.
Yeah.
So then you can match that up. And sometimes the blood work may come back and you may be normal.
Right.
Maybe a low normal.
Right.
And your typical primary care doctor may see that blood work and say, hey, no, you're fine.
Right.
Your levels are perfectly fine for
You're
a 60-year-old
normal.
woman.
Yeah.
Well, yeah,
Right.
your estrogen's undetectable. That's exactly where we want it for a 60-year-old woman.
Yeah.
But that's not really the goal, right? The
Right.
goal of hormone replacement is to get the level back to where it was when we were younger. We want to find in a woman specifically, we want to find that sweet spot of where that estrogen and that progesterone are in balance with each other. During the normal menstrual cycle, there's some days where you feel a little bloated, feel a little crummy. Then there's a few days where you feel just spot on. That's what we want to do. We want to find that spot on point with the dose. And so when the pharmacy's involved, we can help make dosage recommendations. And in our practice, that's what we do. We do what we call the patient care triad. We have the doctor, of course, heading everything up. We've got the pharmacy where we're looking at things, different dosage forms. Are we going to do a cream? Are we going to do a pill? Are we going to do a sublingual? Are we going to do a pellet? We look at that based on the patient's lifestyle. And then the third part of that triangle is the patient.
Right.
We have to listen to what the patient needs and what they want and what their life looks like. if they have a little baby at home or young child, say we've got a younger woman, maybe in the 40s, still producing progesterone and estrogen, maybe all she needs is a little testosterone.
Right.
Is a hormone cream the most effective and safest thing for her to put on her skin when she's got maybe
Little
a
people.
child at
Right.
home? No. So that's where the pharmacy comes in. Is we can say, hey, well, maybe we do something different. Maybe we do the pellet. Maybe we do a sublingual, and take those lifestyle things into consideration.
So talk about those forms quickly.
Sure.
So sublingual, or you also can do the troche.
Yep.
Yeah.
Yes. So there's many different ways to do it. Every dosage form has its own pros and cons. I would say that probably the most common in my practice is to do a transdermal cream. And why that's important, a little bit of chemistry for you. There's certain hormones that are safe to take by mouth. Okay, progesterone is very safe to take by mouth. Testosterone is safe, but it doesn't really work. It's not
effective.
efficacious when you take it by mouth.
Right.
The liver destroys it because unfortunately our livers don't know what's good for us. They just take it in and they try to get it out. So the testosterone, yeah, we can make a capsule, but it's not going to really do anything for you. And then estrogen, we don't want to swallow the estrogen. We want the estrogen to get in the body, go into the bloodstream, avoid the liver. And that estrogen is swallowed, it goes to the liver, changes into some metabolites, and those things are what are associated with the clots. And we want to minimize the risk of that. And so as far as the dosage forms go, we can put all those in a cream where the lady just has to do it once, twice a day. Creams are really nice. The levels stay nice and steady. Trade-offs, as I've alluded to, potentially could transfer to someone else.
Right.
We don't need any estrogen getting on your husband or on your grandkids or anything like that.
You don't want estrogen on your husband.
No, we don't need anything.
We
with
don't
that.
want to feminize our husbands.
Exactly, right.
No, we don't.
And so, but basically estrogen, we need to get in the body in a way other than by mouth. Okay. And I would encourage, any listeners, if we're taking anything by mouth, see if there's maybe another option for you. See what your doctor has available for you, because that's something that, in my opinion, is something that we want to stay away from generally. Okay, so creams work really well, but they also take some time to kick in.
Right.
And so when I sit there,
That's important.
Yes.
Yeah. You're not going to put the cream on today and then you're better all of a sudden. There's kind of a ramp up.
Yes.
Yes.
I've learned that lesson the hard way in my career, because ladies will come and you're ready for relief right now.
Yeah.
And
yesterday.
I get it. Yes.
Yeah.
Exactly. So that is something where I always make sure, hey, you're going to have to give this a few weeks, and it's going to be subtle. It's going to creep in subtle. I personally don't like to make any changes to a cream regimen until the patient's been compliant with it for at least 2 months. 3, really better. But you'll get to that 3-month time point. And you'll look back and you say, hey, you know what? That did kind of creep up. I do feel a lot better than I did a few months ago.
Yeah.
So creams are really, really good. They just take some time, potential transference. Probably my second favorite option, I would say, for females would be maybe the hormone pellet. Okay. We can put it underneath the skin. It's released over a period of time. What's nice about it, you don't have to remember to take anything. It's just implanted, goes into the bloodstream, avoids that hepatic liver metabolization. So those are really nice. Downside, you've got to go have a little surgical procedure. That's minor. Doctors can certainly be good at it, but that's a trade-off. Probably, I would say maybe my third option would be the troche or the sublingual. And it works really well. We'll do that in the younger ladies sometimes. The trade-off, the con about doing that is the levels are a little bit more erratic. You get more peaks and more troughs versus the first two that I mentioned are a little more steady. But sometimes that's the best thing for the patient.
Yeah, that's good. And thank you for going through those, because when I'm talking to a patient, I'm trying to say, okay, because they know there are estrogen pills out there.
Right.
They're like, can I just take a pill? And trying to explain to them, well, no, you could, but that's not what we recommend, because, it changes when it goes through the liver, that first pass effect, all of that kind of stuff. For somebody who's completely new to this, they just have not a clue.
Sure.
Things like transference to pets and to their children or little people or spouses, those things are important. So I think that's really, really good to know. Also, pellets, which some people think that they're new, but they've been around for decades.
They really have.
And that's when you do the implantation of a little pellet of the hormone underneath the skin. And it's just a slow release. I think that's closer to kind of the natural thing that happens. It doesn't wax and wane. It's just kind of there until it's gone. So I think that's great. So how do you help as a pharmacist? How do you help to monitor patients as they're undergoing that hormone replacement therapy? I know I do blood work. So as a pharmacist and a compounding pharmacist in particular, how do you help with the monitoring of that treatment therapy?
So in our practice, we'll monitor it. We have some symptom questionnaires. We'll have a baseline, and we'll look at that over time. Frankly, and we try to practice things the old school way, where we actually have relationships with people. I know a lot of my patients. I know a lot of my doctors, and I'm sure compounding pharmacies around the country, you'll find the same type of thing. But basically, they come to me and they will talk to me. And if I have a consult with someone, I'll give them a call a few weeks later. They may give me a call. Let's say they have a doctor who's maybe not as in tune as the illustrious Dr. Jill Waggoner with the whole process. The patient could come to me and say, hey, I had some lab work done. My doctor doesn't really know what to do with it. Could you take a look at it? In our practice, we even have the ability to do some simple hormone tests. We do some saliva tests, or we have some blood labs that we could refer people to pay kind of a set price if maybe they don't have insurance or what have you. And we can certainly make a dosage recommendation to their doctor. And we do that all the time.
Yeah, that's good to know, because first of all doctors don't know about hormones. And patients anticipate that all doctors know about everything, but hormones are really kind of a unique niche. Not a lot of doctors, when we go through endocrinology is one of those things in medical school where there's so much to learn that many doctors are just, it's like, what do I need to know so that I can pass this test? Because this is so complicated, I won't ever get it. And so as a physician, unless you go back and study some more, you don't understand. So I see patients who will come into me sometimes, they've seen somebody else and they've just done a FSH. They didn't do estrogen. They didn't do testosterone. They didn't do DHEA. They didn't do they didn't do anything. They did one single hormone and they say, oh, you're fine. Well, how can you tell? You haven't looked at anything else. They do the same thing for thyroid hormone. So to have as a resource, even for patients to know, listen, you can get a salivary test and then you'll have all of these specifics and can work with you guys to even make a recommendation to the doctor. I think that's just an absolutely great thing for people to know. So is there anything else that you think that people would know as they approach this? We've talked a little bit about symptoms. We've talked about how to decide. Are there any people that from a pharmaceutical standpoint, you would absolutely say they should not do hormone replacement therapy?
That's a really good question. And let me kind of answer that here in just a moment. I want to piggyback on what you just said. I think it's really important for the listener to know that doctors and pharmacists, you aren't necessarily taught information about bioidentical replacement therapy in medical school, in pharmacy school, in nursing school. A lot of the curriculum that comes, at least in my pharmacy school experience, is based on commercially manufactured products and the studies that are associated with that. And what I mean by that is those are products that are made by drug companies,
right?
Your Pfizers, your Eli Lillys, et cetera, versus the bioidenticals are made custom in a compounding pharmacy. And so since it's so customized, they don't really have that embedded in the curriculum for doctors and pharmacists. So it really takes someone like Dr. Waggoner, like so many others around the country, to go out and research this on their own and learn and attend conferences and read books and practice it with their patients. And so I just wanted to make sure the listener understands that. In general, there's a few what we call contraindications, right? That makes it a little bit tricky as far as giving patients hormones. If they have a history of breast cancer, that severely limits the options that are on the table. In men, I know we're not necessarily talking about men, but prostate cancer, history of that, any sort of blood clotting disorder. Usually a genetic thing precludes it. But one of the common questions I get is, I turned 65 and my doctor made me stop taking hormones because I'm too old, apparently. We have ladies who are in their 80s who are still doing bioidentical hormone replacement. No issues, no problems, tinkering with the doses over time, quality of life much, much improved over where they would be if they didn't have the hormones, in my opinion. And so age isn't really a factor, is the one thing that I want to point out there. If we take the hormones away, so that's another question. Patients will ask, well, what if we stop? Can I stop this? Well, of course you can. I mean, that's your decision. You ultimately have the final say on that. Well, what's going to happen to me if I stop it? Well, you're going to go from having hormones to not having hormones.
And what does that look like for you?
Yeah, and that's exactly where you would be if you hadn't done the hormone. Your body just goes back to the way that it was. So.
Yeah, I think that's good stuff. Well, listen, I appreciate you coming. I really, really do. This has been a great conversation. I think we'll have to plan to have you come back and talk about hormone replacement therapy in men.
All right.
Because women talk about this stuff, men talk about it, but not to the same degree. And we have these places now that they can just line up and just get some testosterone. And I think there's a conversation that's worthy of being had. So
certainly. Thank
you. I appreciate it. He's at PharmD Solutions, which is in Arlington, and I absolutely love them. I've sent patients there forever. We go there also, my family. And so thank you again for coming out. So listen, guys, make sure that you share this with people that you know and love so you can get some good information. It is critical that when you are making these decisions that determine how you do and what your wellness journey looks like, that you have good information, good sound information, so you are not in these medical streets and out on the internet in the wild, wild west of information, trying to decide what you are going to do. So until next time, I love you guys, and blessings to you and blessings to all of those you love.